Welcome to our Tech Talk on the Simulation Curriculum Building, brought to you by myself, Dr. Lawrence Decker, and my partner, Dr. Chen. I think all of us who've been doing simulation for any length of time have had a situation in which someone stopped us in the hallway and expressed how interested they were in getting simulation as part of their training. And we knew immediately what they really wanted us to do was hours of hard work building simulation scenarios that they would not then integrate into their broader learning plan or likely utilize for any significant period of time. The goal of this talk is to discuss some ways to move beyond this initial stage and really get simulation as an integral part of a program's curriculum. We'll talk about some hints on how to find out what your customer really wants, how to take that and develop a basic curriculum map, and then going from under that into adding some additional pieces of learning that may be beneficial that your customer may not have thought about. And then we'll talk about where on the internet you can get some of the resources you might need to further build your curriculum. For any good service provider, it's important to understand who your customer is and what your customer wants so that you can deliver that to them. Myself and Dr. Chen had a number of discussions about who the customer is in simulation. I think on one level, perhaps the easiest level, the customer is that person who's paying your budget, or in the military setting, the person who's giving you that great fit rep bullet or departmental spotlight. But I think that's an oversimplification of the reality. The customer is also those learners who will be taking part in the training you're providing, as well as the other members of the team in that department who will be benefiting from their newly trained co-workers. And in the healthcare setting, it's also the patient. Whose needs are the most important in this situation? I think we really need to come back at this point to the person who actually talked to us about requesting our services. They're the person that has their finger on the pulse of the needs of their learners and patients. And it's that person who can provide us with that information we can then interpret into a learning plan to help them achieve the goals that the whole team needs to achieve. Once you've established who it is you're working for, you can start to get the information you will need to develop the curriculum. Asking this as if a new or existing subject matter is a good place to start. The material is already being taught, then dovetailing off that instruction, replacing some aspects with more effective instruction via simulation, would be the most beneficial. Many times the motivation for the request also comes about because some other group is already teaching the same topic. In that situation, copying and improving on their method can decrease the workload of starting from scratch. You should also ascertain why the request is coming now. An educational program response to a Sentinel event or a new Joint Commission requirement will likely involve a more focused goal than one done as part of an ongoing process improvement. And finally, see how it fits into their entire educational plan. Does the group in question already use extensive simulation? Will they be using this as part of a larger orientation package? Or will this be a regular reoccurring refresher training? The first step towards building a curriculum map is getting a gold standard or standards. Preferably this will be one or more articles or textbook chapters. Less preferable is using experts in the field. In either case, the standard establishes important material that must be conveyed during the training. Utilizing a written standard is especially beneficial in the military system, as it allows the curriculum to easily outlast the tenure of any one person. From there you can ask if this material is novel to your learners or a refresher of prior similar material. The amount of discussion necessary to introduce a group of nurses to a new urinary catheter procedure would be far less than introducing immediate action steps for tracheostomy bleeding to new critical care nurses. Finally, take a hard look at what the benefits of simulation will bring to the training early on. Answering this not only provides validation that simulation is the appropriate choice for the training, but also highlights which parts of the simulation are necessary for it to be effective, and which ones can be sacrificed to improve reliability and cost effectiveness. From there we can develop a required skills list. For all the simulation curricula that I have developed, one of the first activities I do is to lay out a list of the skills required to effectively complete the task. This may be as simple as the list above for a lumbar puncture, a number more than 100 as it did when we developed a simulation course to expose new corpsmen to field care in a shock trauma platoon. In either case, as much as possible, break that task down into simple skills. This can help identify common steps, such as procedural consent in this case, which could potentially be taught for several procedures at one time. Once the list is complete, then you can establish in which venue the individual skill is best taught.
My name is Lieutenant Commander Jenny Chen, and I'm one of the ER physicians at Naval Hospital Okinawa. Over the past 3 years, I have worked with many of my colleagues, including Commander Decker, on creating medical simulations for our overseas hospital, particularly for the emergency department. I'll be talking about going beyond what we've learned during our second class of this sim curriculum in regards to Mager's learning objectives. Now, I happen to be a big proponent of these traditional learning objectives, mainly because it forces us as instructors to sit down and perform crucial front-end analysis of what we want to achieve in our curriculum design. The benefits are clearly many, to include paving the way for consistent delivery of simulation cases among varying instructors, as well as being able to provide clear criteria, performance, and conditions to measure student achievement. That said, there are some limitations to traditional learning objectives. First, it has been acknowledged that these types of learning objectives are often synonymous with performance objectives. But what if your objective for your simulation is not performance, but rather to have the participants undergo a rare experience, such as the traumatic death of a child, or even something as simple as the physical requirements needed to perform 2 minutes of continuous CPR. There are often strong human reactions to medical phenomenon that cannot be adequately taught or explained by a textbook and must be experienced firsthand. I believe that medical simulation is an ideal venue to teach these physical and emotional components to medical personnel that cannot be palpated or perceived through a textbook. Secondly, these traditional learning objectives often overemphasize objectives and assessments. And one criticism of that has been that it can be demotivating or cause participants to disengage during the simulation evolution. And as Commander Decker will be talking regarding time constraints with medical simulation, this is very important to maximize participant engagement during your short time together to perform medical simulation. I would also recommend going beyond procedural or task-based objectives and consider incorporating human factors into your case scenario learning objectives. Studies in patient safety consistently show that it is not a deficit of medical knowledge or procedural skills that cause the majority of medical errors, but rather usually a drop in communication at a crucial time. Medical simulation is an excellent environment to practice teamwork and communication, but these abstract concepts are often difficult to measure in an objective fashion. For instance, how does one best measure communication? By the numbers of words spoken during a simulation? Well, I think most of us can agree that the volume of communication does not necessarily correlate directly with the quality of communication. I'd like to mention team steps here as a set of tools and strategies for how to teach and promote good teamwork and communication skills. What about leadership skills? It is clear that during a critical medical situation such as a trauma or medical code that there must exist a good team leader. Well, how does one write this into learning objectives? Also consider societal nuances such as gender differences. For example, a medical command uttered by a male physician may be perceived as a good leader, but the same sentence stated by a female physician may be construed as bossy or micromanaging. This has been studied in non-medical fields to be true, and I have no doubt that it also occurs in medicine. Would you consider different learning objectives for a male versus female physician leader? Other factors to consider: disruptive personality behaviors, personal backgrounds of medical staff that may suddenly affect them in the middle of caring for a critically ill patient. Additionally, the art of multitasking is very important for hospital staff. How would you incorporate that into your learning objectives? Patient empathy, good bedside manner, clearly important in medicine. How do you measure good rapport with patients? So while these traditional learning objectives lend themselves very well to procedural or task-based case scenarios, it can sometimes be more challenging to create concrete learning objectives based on these more abstract team and human factor phenomenon. But nevertheless, I think it's worthwhile to try.
Any well-developed simulation curriculum will also include a significant amount of traditional education. Whether it's required reading, lectures, or both, this primes the learner for the simulation portion. It's also an important part of leveling the learning field so that all participants feel that they are in a safe learning environment with objective judgments about student performance. The pre-learning will also allow the student to move beyond the basic knowledge and comprehension of facts to the application and synthesis of the skills in question. Finally, by providing your participants with a described appropriate course of action, it will significantly decrease the variety of response to the simulation scenario. While obviously taken to an extreme this can be detrimental to learning, your simulators will certainly appreciate having the students stick close to the script rather than asking for off-the-wall interventions such as surgical procedures for a case of cardiac arrhythmias. While many of your learners and most instructors will have had some prior experience working in the simulation lab, it is important that we don't presume that they all have our comfort level with the lab. By specifically placing orientation materials in the curriculum, we provide that necessary information, and it acts as a reminder to instructors that learners of many different comfort levels are present in the class. It's important to be honest with your customers about their time commitments up front. Nothing is more frustrating than to put together the perfect simulation, only to have the learners exit without any feedback because someone assumes you cut your time in half. While I have no scientific data to back this up, my experience is that the period of time should be about 2 hours to 3 hours for a single type of learners, or about 60 to 90 minutes for a multidisciplinary team. This allows enough time for learners to actually engage without becoming fatigued. In some instances, this will also include lectures as well. For instructors, the key is reducing preparation work. When utilizing busy clinicians and nurses, they are usually more than happy to teach, but frequently have trouble or are unwilling to take adequate time to prepare for instructing. Also, expecting an instructor to provide more than a half day will greatly reduce the number of willing volunteers, as it makes it hard to squeeze in around clinical and administrative duties.
We are privileged to have among our sim resources a high-fidelity patient simulator on which to base our case scenario designs. However, having this piece of more advanced technology as opposed to a basic non-programmable mannequin can sometimes not only complicate matters but also degrade from the case scenario learning objectives if not incorporated appropriately into the case. As all resources are limited, particularly our instructor time allotted to simulation, it is important to designate where to prioritize team energy and not miss the forest for the trees, so to speak. Here are some examples of where we may have had too much technology on our hands for our own good. The first one, our hospital paid a substantial amount of money to purchase automatic drug recognition using RFID technology embedded into medication vials for our high-fidelity patient simulator, similar to the vial seen on the top picture there. This was touted as state-of-the-art, an example of our cutting-edge medical simulation program. A nurse would simply have to wave the vial over the arm of the mannequin to document administration of the medication. However, if you thought about it, how are medications given or documented in real life? The vials are kept in a back room near the Pyxis machine, and the medications are drawn up from the vials into syringes seen in the second photo there, and then the syringes are brought next to the patient and flushed into the patient's IV. The vials themselves are rarely brought into close vicinity to the patient, so this RFID technology could not be naturally implemented unless the nurse took an extra step and artificially brought the vial with her. Another common situation is when the high-fidelity patient simulator unexpectedly stops working during sim day, such as running out of battery or loss of internet connection necessary to run the pre-programmed case. This can lead to disruptive training timeouts that degrade the quality of sim training, as well as eat into the limited time designated for medical simulation that day. Sometimes, despite the best case scenario preparation, the team chooses to do something wholly unexpected, and the pre-programmed simulation curriculum cannot rapidly adapt to their actions. This is when it's crucial to have a human instructor be able to take over and override the program. Oftentimes, flexibility is a key word, and both the instructor or sim facilitator needs to be able to adapt, think quickly on their feet, and come up with alternative, even lower tech solutions to salvage the sim case scenario.
This slide is just a reminder that as you start to develop professional curriculum, be sure to document your multimedia sources. While it takes a few seconds to copy the website of origin into the show notes, it becomes nearly impossible to go back after the fact and try to find hundreds of images that can make up a whole curriculum. And while for most institutional use no special permission is necessary, knowing who to contact should you desire to present it at a conference or in the future sell your work to someone else will be invaluable.
We use the ACLS, PALS, and ATLS courses as a gold standard of the great integrated simulation curricula. They have the complete package of appropriate reference texts, prepared lectures, and case simulations that build off the prior learning to ensure comprehension. Now, none of us have the budget or the long-term mission of these curricula, but they are still a great goal to strive for. They are also a great resource to draw from for simulation ideas for many of our code and team emergency trainings that we are asked to develop. Interestingly, none of these courses have yet implemented high-fidelity patient simulator technology into their medical cases.
Many fields now have textbook collections of simulation scenarios available from web retailers and medical bookstores. While they're not free, they're certainly far less expensive than purchasing whole curriculum, and they offer cases that are already diagrammed out with learner's decision points and physiologic changes. However, while they offer an easy springboard to a finished case, some caution should be used. They are frequently cases which are easy to simulate, but not necessarily the most clinically relevant to the learner. So they may offer a good starting point and can make for some useful suggested readings for your customer, whet their appetite for what you might be able to accomplish together.
Many medical societies require their providers to participate in oral board and sometimes even simulation-based testing. While the actual test material is a closely guarded secret, a whole industry has grown up around preparing physicians for these tests. These board prep casebooks are often reasonable to purchase and may already be in the library of your subject matter expert. The cases they describe will often be core cases within the field that represent multiple standardized aspects of clinical competency. They are usually already beta tested to ensure that the scenarios and prompts are clear and helpful. Additionally, these cases will often have representative physiologic responses, appropriate interventions, and ancillary data such as EKGs and X-rays that are helpful to look at and help write your scenarios.
This is by no means an exhaustive list of websites. It is heavily weighted towards emergency medicine, in part because of our background as emergency physicians. I mention these websites mainly to highlight that prepared curriculum does not actually need to cost anything. These were all found via a Google search, and many of these cases provide an adequate review of required learning and may even include valuable images and EKGs. Finally, you can consider purchasing fully developed curriculum. Lairdale has the best developed site for this, but other manufacturers also have similar services. They offer hundreds of cases, usually grouped into curriculum based upon the type of case and the suggested audience. They are beneficial in that they are often designed to work seamlessly with your equipment, freeing you to interact more fully with the learners. They do cost several $100s though, and can put the cost of curriculum out of the reach of many programs. They can also suffer from excessive bells and whistles put there to make the simulation sound more complex without benefiting the knowledge transfer. Finally, once you've completed your curriculum, I can't overemphasize the importance of appropriate packaging. If you spent days on this project, make it look like it. Have a standardized way of documenting how to set up your cases and what each section is teaching. This improves the handing over the project when you move on, as well as shows a level of professionalism to your customer.
This concludes our presentation on simulation curriculum building based off of our emergency medicine and overseas community hospital perspective. Thanks for listening, and we hope it will help you generate more ideas for your own curriculum and case scenario design.